What's up, everybody? Welcome back to PhysioDisc. Thanks for joining us for this second episode in the hip injury series where we're going to take a look at muscle injury, and we're talking about strains and tears here. We've talked about those before, but this is going to focus on the musculature at the hip and the trunk specifically, and even into some of the lower extremity. Basically, these are the most commonly injured muscles, the most commonly strained or torn muscles in the kind of rotation-centric athlete. We hope you're going to find this informative. We're also going to show you some rehabilitative type exercises, so make sure you hang in there and catch that toward the end of this video. Now, in previous episodes, like Intro to Injury, Shoulder Series, blah, we've talked about muscle tears. We kind of have an idea what those are. For the sake of making sure that everybody watching this video, if this is your first one, you have some type of idea. A muscle strain or muscle tear is when there is injury to the actual contractile units, muscle bundles and fibers of the actual muscle belly. And this happens when they are stretched beyond their mechanical lengthening limit and they tear. Muscle strains are actually a form of muscle tear, and there are different varying degrees. There's a little bit, a middle amount, and then a full-blown tear or a rupture. And all of those types really vary on the severity of the number of muscle fibers that are torn. Especially in rotational centric, you're kind of having to do isometric control and then control extension or elongation and then back into a concentric contraction. It's kind of that oscillation between those three types of muscle contractions. Muscles are actually strained or torn when they are forced into elongation from a state of kind of an isometric contraction or even a concentric contraction when they're not prepared for it. And that is just a brief overview of what a muscle tear or a rupture consists of. Now, in the first episode, we looked at the anatomy around the hip, and much like the shoulder, there's a ton of stuff going on. There's lots of muscles, tendons, ligaments, whatever. But in terms of muscles, there's a lot going on at the hip. And for that reason, and because we are such functional beings, it's very easy to injure those muscles around the hip. The most common muscles that are torn around the overall hip and trunk musculature in throwing athletes or that rotational centric athlete are the abdominals and obliques, hip flexors, hip abductors and adductors, and then the hip extensors or the glute max. And much like in the previous video, we talked about how a lot of people don't really think about the abdominal muscles or the obliques or core musculature as being a part of the hip, but we do consider them to be sort of a part of that lumbopelvic hip complex because they share some point of attachment on the pelvis itself. Now, in terms of muscles that are most likely injured in the kind of the core and abdominals area, that would be the abdominals or the obliques. The abdominals, the internal and external obliques are all what I like to call big movers of the trunk. So abdominals help you flex, those obliques help you twist. So they're not intended to be stabilizer, your initial stabilizer. The true stabilizer, as we discussed before, is a transverse abdominis. Now, these injuries don't necessarily happen because your core is weak. It doesn't mean that your core is weak because you get a hip or lumbopelvic hip complex injury. Now, what can happen, especially in these rotational sports, is that instead of allowing your glutes and your lower extremities and posterior chain muscles to drive your hips around and through during a drive, what actually can happen is either because of poor coordination or poor programming or poor learning of this movement, you can use your obliques, your big rotational movers, not going to talk about the back right now, you use some of those big rotational movers to do that movement for you forcefully, and instead of it creating a lot of power from muscles that are meant to create a lot of power, you're using your upper trunk, and that's how you can injure those abdominals or obliques. I actually tore an oblique several years ago in preparation for a tournament. I was on a course that was a little bit longer than I was comfortable playing, but I determined I was going to play this course, and instead of working on form, letting discs do the work for me, I was just really trying to muscle a disc through on holes that I had no business trying to throw as far as I was trying to throw. I was young and dumb then, and now I am not quite as young. So don't be like me. Don't use your core musculature to rotate your trunk and around and through. That's a job for other muscles at your hips. Now, the hip flexors can cause a real problem for some folks too, and that's in, sprinters, basketball players, soccer players, football players, lacrosse players, rugby players, whatever, where you have to have those quick bursts of speed, quick movements, at least, that can really cause a problem for the hip flexors. Now, for disc golfers, they can be an issue too. If you're someone who, during their drive, that cross-body step, as you're pulling back in it, right before you come through, if it is an exaggerated step over across your body, or if you were leaving your plant foot too far behind you when you follow through on a forehand, you really can and do risk injuring those hip flexors because they're in kind of a isometric or even concentric contraction, and you are very quickly forcing them into extension. Now, if those muscles are not prepared for that action, that's again when that muscle strain or tear can occur. Now, this can happen in other shots too, not just drives. So if you are someone who has a very forceful jump putt or step putt, it's not unheard of to strain those hip flexors. And again, this happens because you move from the muscle state of being either isometric or concentric contraction, either holding one length or even shortening, and then switching it and forcing it through. That does happen during the drive. Your lead leg or crossbody leg plants, it's stabilizing, even getting concentric contraction as you kind of come over it, and then you rip through and push through and extend over. I mean, yeah, for sure. Now, I run the risk of hurting a lot of feelings out there with this next one, and that's the adductors. And if you are someone who frequently injures their adductor or kind of like the groin muscle area, and especially if you've done it playing disc golf, you have a really weak butt. Sorry about you. That's a common leading factor in adductor strain. What happens is because your glute medians aren't able to stabilize, or glute max isn't able to do that full extension, the adductors, specifically adductor magnus, will help do that extension job. And so I've gotten several runners who their stride is just kind of falling apart over time, but they start to compensate for that hip extension when they're pushing off. Adductor magnus is helping get that hip into extension. And they go on long runs and they're like, oh man, one of my groins hurt, one of my adductors, well, how did I strain these? How did that happen, Andy? It's because they got weak butts. Now, just like your hip flexors or your obliques or your abdominals, your adductors can be overstretched. If you're thinking about drives, when you are doing a backhand and you plant and you come through and you drive through with those hips, if you aren't getting that hip extension through your glutes, your adductors can help and they can be overstrained there. Or maybe you're taking too long of a crossbody step on your approach. Or if you're doing a forehand, I've seen it all the time, people taking that step and then dragging their back leg as they follow through. You bring yourself into like Jean-Claude Van Damme time cop splits, man. You can definitely injure those adductors because you've moved into such an increased or forced stance of abduction, legs away from center, and you're asking your adductors to brace in an overstretched position or even help in a hip extension. As far as hip abductors go, they're mainly doing just a lot of stability at the pelvis. Your glute medians are meant to stabilize opposite sides. So if you have somebody that's got a hip maybe that's sagging on the right side, their left hip abductor is not doing its job. And I realize it's probably flipped in the video, but I apologize. Sure, those can be torn and those can be strained, or any type of dynamic movement, twisting movement through the hip where they're in a concentric position and then asked to elongate. Now, thinking about the glute max or the big fellas back there, if you are using them, that's a big if, because there are a lot of people walking around not using their butts like they're supposed to. Like I've repeatedly said in this video, the glute's main function is to move hip extension. They drive hip extension. And as we've covered before, and as you know, if you've looked at any kind of form videos, you gotta have hip extension and drive through that leg. The hamstrings help a little bit with that, sure. But the glutes perform the most powerful hip extension movements. Now they also help to stabilize the hips, much like their little brother's glute med, and they work to help keep that pelvis from any type of non-essential movement so that you're not robbed of efficiency. And again, referencing that cross-body step during your walk-up, during your drive, you typically are planting that foot in a position that does not necessarily lend itself into external rotation at the hip. That's why you see a lot of guys pivot or spin on their heel with that extended leg. Because if you pivot and turn on your toes, one, that's really, really bad torsional force on your knee. but two, that robs some of the hip extension that you're gonna have. Now that plant foot is working to stabilize the hip as you take that initial cross-body step and plant. Your glutes technically are elongated in that position, right? I've been saying that a lot of these muscle tears, most of these muscle tears come when they're concentrically or isometrically contracted and then pulled into elongation maybe before they're prepared for that. These muscle injuries also can come from long, sustained, heavy load injuries to that muscle that they're just not ready for. Or maybe there was a small tear started from something else and exacerbated when you call on them to act quickly and with a lot of force. Is when you go in an elongated position here in the plant foot and then moving into hip extension, forcing into hip extension. So it is kind of the opposite, but you can tear that muscle doing that. Ideally, having some type of imaging available is always great. The best imaging method to look at soft tissue such as muscle is an MRI. Those things are expensive. And if you're someone who is paying out of pocket for that, it can be quite a bill. If your insurance covers it, you met your deductible, go for it. That's the gold standard. That's the best picture of that muscle in addition to a manual evaluation. But physical therapists cannot order those. We can recommend that to doctors or talk to doctors and be like, hey, we're trying conservative therapy, it's really not helping. It would really be nice to have some imaging. And if they agree with that, our assessment, then they can go ahead and order those. And those are very helpful. But like I said, maybe that's not an option, money or whatever. The best way for a physical therapist to tell if a muscle is torn is we use something called a special test. We also use manual muscle tests, which we've talked about before, but manual muscle tests are used in conjunction with those special tests to really rule in or rule out a muscle in question. Now we also look at muscle performance and things like that in different types of observed activities, functional movements, movements that they do in their daily activities. But for the sake of time in this video, we're just going to talk about special tests. And the special test that I'm going to talk about, at least for this video, is the Thomas test, which is a common assessment tool used for the hip flexors, namely tight muscles, but that can also give you some information into potentially strained or torn muscle. Now, when looking at the hip flexors in the Thomas test, there's a lot of muscles to account for. The hip flexors are not just like a 1-2 thing. I mean, you're dealing with the iliopsoas, you're thinking about the rectus femoris, talking about the sartorius, the pectineus, the gracilis, and the TFL, or the tensor fascia latae. Now, in the Thomas test, the therapist assists the patient into a supine or laying on their back position. Before they help them down, the patient tucks the opposite or the unaffected side. Really, you're gonna look at both sides, so you can start with whichever. I like to start with the unaffected side first, just to kind of see what I maybe should be seeing. You're gonna take the unaffected side or affected side, knee up. Physical therapist is gonna help you lay flat on your back with that knee still tucked up to your chest. Now the therapist will then inspect the side or the lower extremity that is not tucked up to your chest. The one that's held up to your chest is not the one we're considering right now, so don't even worry about it. At this point, the therapist looks for a variety of things. One, we're gonna look at the small of the back or the lumbar region. Does that lumbar region stay flat to the table or the bench or whatever you're using? If it does not, you may have tight hip flexors. They're pulling that hip, rolling it forward, relative anterior hip flexion, but back extension, right? Number two, we're gonna look at whether or not this leg that is down, that knee naturally flexes to at least 80 degrees. If it doesn't flex to at least 80 degrees, we know that the rec fem is involved and it's gonna be tight. Number three, we look at whether or not the hip extends or flattens. If your hip stays in a flex position or bent position, we know that the iliopsoas is involved, because that is a one joint muscle. Number four, we look to see whether or not the femur is internally, externally rotated. If it's externally rotated, sartorius may be involved, or if it's internally rotated, pectineus may be involved. And five, we look for whether or not the femur is abducted or adducted. Is it midline or not? If it's abducted, could be TFL, pocket muscle. If it's adducted, it could be gracilis. And finally, number six, we look at whether or not there is a combination of any of the previous kind of scenarios listed. For example, if the hip is still flexed and the knee is straight, we could say that either rec fem or iliopsoas is involved, because the hip could be affected by the iliopsoas or the rectus femoris. We can't necessarily say that the iliopsoas is the only one involved, because if the knee is straight, that couldn't be the iliopsoas because it doesn't go down that far. The rec fem is definitely involved, so we can say that it's just the rec femoris, but we can't say that it's just the iliopsoas alone. Now, in terms of healing times, obviously those all vary depending on severity, but I'm going to put these up on the screen here. A grade 1 I mean, you're generally looking at around 2 to 4 weeks. That's generally speaking. You know, that's ideal kind of healing rate there. You know, no complications, anything like that. No re-injury, you know, you're doing your therapy, doing everything you need to be doing. Grade 2, up to 3 months. That's a little more of a significant tear. And a grade 2 is anything over a grade 1 all the way up to the teeniest, tiniest fiber that's left. The grade 2 is actually it's kind of the largest range of tear that can happen, you know, before you get to that grade 3, which is a rupture. That can take from anywhere up to 6 months or longer. And that's generally a surgical repair, but those muscles are gonna heal faster than your other cartilaginous or tendinous structures just based on their vascularity, really. They naturally have just this higher availability of those white blood cells and those healing factors, you know, from your blood, and they are flooding that tissue anytime that muscle gets used, unlike cartilage or tendon. Now for my bread and butter, and that is rehabbing those muscle injuries. Depending on severity, if you're looking at like a pretty bad grade 1 or grade 2, you know, more than just the delayed onset muscle soreness, initial rehab is gonna look like some passive range of motion, unless you can tolerate active range of motion on your own, if it's not such a bad tear. Then you're gonna do, you know, active assisted range of motion, then active range of motion, then resisted, and then into functional things in the end. And then all the way throughout, you're gonna be doing some forms of either static or dynamic stretching of those injured muscles. Now, at this point, I want to strongly suggest that you don't jump right back into some type of resistance training if you think that you have a torn muscle. And that's especially if you have anything over 5 out of 10 pain with any of that stretching or the range of motion exercise. Now, the following is just kind of a general program for someone wanting to work range of motion at the hip. And this is at the point where they've moved on to sort of the ability of being able to do that active range of motion. Now, there are a couple of important factors or principles to keep in mind when you are looking at rehabbing muscles that potentially have been torn. And those are really related to just kind of knowing what type of rehab you should be going to first. So first off, if you notice that a muscle is having difficulty achieving a full contraction, maintaining that full contraction, or is it accompanied by like shaking or early fatigue? If this is the case for you, you may not be necessarily struggling with a lack of strength, but more so a breakdown in that connection between your brain and that muscle, or that motor pathway. And we call this the neuromuscular connection. In order to reestablish that neuromuscular connection, we do something called neuromuscular reeducation. And that involves a series of types of muscle contractions that have been proven through research to be the most beneficial in helping to reestablish that brain muscle pathway. One easy way to remember that scheme is think of the word ICE. And that ICE stands for isometrics, concentrics, eccentrics. And that's the order that you progress in muscle contractions during your rehab. Now, in this scheme, heavy resistance is not necessary at all. We're really looking just to reprogram that movement. Then once you feel like you can get good strong contractions that you can hold, you don't fatigue too quickly, then you can look at moving into that strengthening scheme, where you're focusing on eccentrics and concentrics. Eccentrics have long been thought to be the most challenging muscle contraction for your muscles to make. You've heard people talk about time under tension. Spend a lot of time in elongation, or even training that eccentric or controlled elongation, because it's so hard for your muscles to do. Now, there is research out there that would support the idea that eccentric contractions or controlled elongations of muscles are the most difficult for that muscle to perform, thereby being the most beneficial for muscles and tendons, right? However, I'm here to tell you that the most important principle to remember if you're trying to build strength is time under tension. The longer that muscle has to work, the stronger it has to be, and the more endurance it has to have. If your reps are sloppy, you're getting really good fast concentric or even fast eccentrics or real quick isometrics. If they're sloppy, you're not doing as much benefit as getting good control, time under tension, really loading those muscles. The mechanical load is what causes those muscles to grow, and the more time they spend under the mechanical load, the more that they have to respond by either growing or becoming stronger or being able to stay under contraction longer, i.e. building endurance, so forth. As with the previous routine that I showed you for just kind of general range of motion, I didn't jump right into the most difficult thing, right? And so when we think about like strengthening and stretching, we also don't want to look to jump into the most difficult thing like deadlifts, squats, leg press, loaded good mornings, things like that. Because if we're talking about a muscle that is not fully healthy, to get that optimal healing and giving it the appropriate type of resistance and stimulus when it needs it, we need to kind of look to that slow progression in difficulty. So the following is just a simple hip strengthening and stretching routine that I put together for you. may have noticed that I really didn't give any type of rehab or prehab tips for the abdominals or the obliques, but I did talk about those as being some really commonly injured muscles in the lumbo-pelvo-hip complex. The reason I did that is because those are going to be included in another video talking about core strength and how it kind of relates to back pain. But when you are looking to rehab the obliques and the abdominals and kind of that core musculature, you're really just wanting to start off with, it's not really possible to do passive range of motion unless you have somebody who'll kind of roll you around on the floor. But otherwise, you're gonna want to do some really just gentle, light, active range of motion, just to start out with until you start feeling better, and then slowly, progressively move into some type of load. But like I said, we'll talk a little bit more about that when we talk about core strength and how it relates to low back pain in a future video. And if you have any questions for me in the meantime, please reach out to me directly, either through Facebook, comment below, or you can reach us through Instagram. But we will unfortunately not be discussing that at this time. So that right there is the quick and dirty of hip muscle strains and tears. I really hope you gained something from watching this video. And we at PhysioDisc will never dissuade anyone from asking any kind of questions or reaching out to us. Maybe ask for more info, or maybe even ask for more about more specific scenarios. So if you're looking for any type of clarification, please don't hesitate to contact me. Next time, we're going to be looking at tendinopathy at the hip, which is sure to be an info-packed and rehab-heavy episode. So do yourself a favor and make sure you check that out. As always, stay excellent.